Thank you, everybody, for joining us. This has been a great morning. We began very early in the morning with the WHO chief scientists telling us the changes we need in our healthcare and how to make sure that we are better able to match the needs of our patient communities and better able to understand them. On this session, we are looking at fragmented healthcare systems. We are starting from the premise that we just passing through a great pandemic, which may or may not, I think we're waiting for the jury on this, have been exacerbated by fragmented healthcare systems, healthcare silos, convoluted and complex care pathways, and the worst of it, communication, informatics, and others, that the center did not know what was happening at the periphery, and the right hand did not know what the left hand was doing. And then lack of community ownership, and that drives us to the solution that we had, like many things, ready-made solution already presented in the WHO framework on integrated and people-centered healthcare. That was implemented in fragmentation in one way. Joining me today is an excellent panel, and I've known the panelists very well. First panelist you're all familiar with is Eric from the International Hospitals Federation. He's the chief executive there, and Eric is so passionate about these intelligent hospitals. I'll have to control him. I think it's he has so much to say, but it's absolutely, you will be enwrapped in his passion on this. And he's continued this at the primary healthcare in Astana, at the WHO, and he's always pushed this, that the hospital is not just a building, it's a system, it's people, it's communication and networks, and the hospital is an octopus, like putting its tentacles in all the communities around it. Then I've got Shiva Singh from Scala. Shiva and Dr. Vijay Rai have worked extensively on DFID and other international projects to try to help integrate low and middle income country health systems. I met them in Saudi Arabia at a very important juncture when G20 was meeting, and at the same time we had the global patients safety going on, and then we had additional seminars on looking at how we can look at the Ministerial Congress, which was very important. And the Ministerial Congress kind of summit showed us that we need this system. So without much ado, I think what I'll now do is I'll ask Eric to take the floor, and then followed by Dr. Shiva Singh, and then Dr. Raval, who will share a presentation. Thank you, panelists, and please go ahead. Thank you.
Kawaldeep, thank you very much. And it's really at the same time, you know, a great honor to be invited to your conference, but also I always say continuous pleasure to be invited in such conferences. As you know, the International Hospital Federation puts a lot of importance in its relation with the APO, because we consider that organizations like yours are really critical in the way we can shape up and evolve the health system. So you asked me today to discuss, how, hospitals should be digital hubs for patients to better serve them. So this is going to be some kind of an overview, of course, because the way we can share that is depending on the countries, the regions. So I can only make a generic presentation. But although I'll be generic, I want to start with the fact that when we talk about hospitals, we always have diversity in mindset. You see these two pictures. How could you compare what is almost a town on its own, a huge university hospital complex, and a small building with few staffs, which is the rural hospital in the middle of nowhere? Even though these organizations might be very different, we face more or less currently a number of similar challenges. Complexity of patients, not because the patients are more complex, but because the science allows us much better to address the complexity of the patients and not pathology by pathology, but holistically. The fact that we have more and more players, many stakeholders involved in healthcare, health and social care, which I will come back, which is important. The fact that everybody wants to avoid to go in institutions. There is a big push all around the world to find solutions to be treated rather at home than in organizations. Of course, there is this movement on patient empowerment, and you are playing a role for that, and this is a great evolution, and many technologies opportunities. COVID-19, as you said, has really underscored these challenges and these trends, and behind that, we have seen that digitalization is playing a major role to face them. When we talk about digitalization, we are covering also many different areas, and I just wanted to make sure that we cover the different dimensions. There is one dimension that is, for me, very critical for us, is that health information is really ubiquitous and owned by the individual to which it is related. So that's a big chunk related to digitalization. There is another important component, which is moving also with all the genomics and all that, and the micro treatments, the specialized treatment, which is also very much linked up with the evolutions of technologies and digitalization, is individualized care. Of course, we have the data intelligence. A few years ago, you could not have a conference without talking about big data. It means that we have the capacity with the volume to find more interesting solutions to bring evidence behind the decisions. And plenty of elements of technologies that is affecting the way people are treated. Of course, all the wearable that gives responsible to the individual and allow the individual to be piloting a number of parameters related to their health, but also we have the robotics that can substitute to the health workers as well to be the complement of health workers. So a lot of movement that is around the microcosm of the hospitals. But if we want to integrate, and we certainly support the WHO framework that you discussed and you showed this morning of integrated and patient-centered care, we believe that there are a number of enabling conditions that are there in a number of countries, are not always there in other countries. One of them is more at the level of policymakers. It's a payment system, a policy framework, and a comprehensive electronic health record system. These are three pillars that are necessary for integration of care. You also need, for those who are in charge of health service provision, people that are visionary, that see the long-term benefit for fulfilling the mission that we have in providing health to the population versus facing only the short-term constraints that might play against this integration. We need empower patients because they are the ones that can best take the responsibility about their health, but they have also to participate in decision. And all three have to work together, so we really need to have collective mindset. And we have seen through COVID kind of a tension between reactions like I take care of myself first, and this big movement saying that we are much more intelligent working all together to find solutions. So we believe that integration is on the move, but the pace may vary. Hospitals in that have been kind of a magnet over the years. We have been attracting the professionals, the technology, the resources, and often also the people, like working on our own, ignoring the other players, sustaining ourselves, and trying to deliver within our sites most of the services. I think this image of the hospital that is still very present in the mind of the people and in the reality in a number of countries is fast evolving. And really the vision we have of the hospital as an integrated and digital hub is a hospital that is relating and correlating with all the stakeholders, from home to respond to all this real important demand, from primary care provider for rehabilitation, which is really, really very important, especially with aging population, And for the social care, that is also a very important dimension in relation to the social conditions and and inequalities, but also to the aging populations. What do we expect now? And this is going to be my last slide, out of a digital hospital that is supported and empower patient. We expect this hospital to have the capacity to reach. That means to reach widespread, really strong evidence-based health behavior interventions, because we know how much health behavior is also important if we move from disease to the health capital and maintaining health. We also envision that quality should be, a continuous driver, and having an organization that is, at the center of all this movement, of all this, is very important to make sure that you have quality insurance systematically provided. We hope that there is strong personalizations. We've talked about individualized medicine. It's much more than that. Each individual has his own profile, has to be taken on board as a person fully and not as a combination of pathologies. So that's the third element. And the last one is the engagement, because we believe that patients have a key role to play in taking care of themselves, but also in being involved in the hospital. And that gives, more or less the last element I want to share to you and say, let's look at the journey that we have done as a patient, because at the end of the day, we are all patients. Not so long ago, we were all just beneficiaries. That means we were lucky to get the care that the professionals were willing to give us. From there, we have moved to be more consumers. That means at least we started to look and say, well, among those offering care, some are more responding. I can come and pick up the one that I think are the most corresponding to me. Now, the big trend, and really widely supported, especially by WHO, is to consider that we are partners, that health is a co-creation between the patient and the professional. I think now we need, and I think a digital hospital that is empowering the patient will need to make the last move from partners to really stakeholders. That means considering the patients as part of the decision makers and part of the whole choices that are made, not only for one person in regard to these treatments or condition, but as a community in regard to the services that need to be provided to it. This is, in a nutshell, the messages I wanted to share with you, and I guess that we'll have more opportunities to share additional thoughts and discussions in the Q&A afterwards. Thank you very much.
Thank you very much, Eric. Vijay and Shiva, I think Eric has just thrown the gauntlet for you. How do we scale up from a small hospital to an entire health system that's integrated? And how do we address all that we have seen during this whole pandemic, left not knowing the right? And also, lastly, and very important, because we were at the G20 and other meetings that we looked at, does this solution apply in low and middle income countries? So I'm preemptive that question. Please show your argument and how this is taken into low and middle income countries as well. Thank you. Take over.
Thanks, Kaldi. Thanks, Kaldi. And thank you to the IAPO for inviting Escala to come to join this webinar. So this slide up here just tells you a little bit about my passion for patient safety in learning. And it just showcases a couple of the projects we've worked on over the past couple of years. I've been involved with multiple NHS projects and with the UK Sepsis Trust to implement learning management solutions and modules for the UK Sepsis Trust, which went out to many hospitals and to many doctors and nurses to train them on the awareness of sepsis. The other projects which I've worked on is the Ministry of Health in Egypt, where we looked at patient pathways for GPs. We brought over about 100 GPs over to the UK to train them on patient experience and what a patient experience would look like in the UK and general practice. But more importantly, to look at the electronic patient record systems and the integration of digital health within a patient environment, which they found very interesting. And I will talk about that project a little bit later on. But the last project I want to talk about is the Ministry of Health in Saudi Arabia, the KSA Sepsis project, where Escala initially led a team of consultants working with the Ministry of Health and the King Saud Medical City to look at the important topics of sepsis. We recruited some subject matter experts from the UK, the Global Sepsis Alliance, the UK Sepsis Trust, Health Education England, and Public Health Wales to produce and analyse data. So we looked at the current state of position of sepsis in Saudi Arabia, and that was by delivering workshops and going face-to-face to hospitals to engage with emergency medicine departments. We examined the detection of early sepsis. We looked at the lack of data, which they had, and we looked also at the limited community awareness and also about the standardising of learning, because they did have some sepsis learning, but not enough. We then looked at putting a report together for the Minister of Health, but also looking at the models of care of sepsis globally to establish best practice. Escala's recommendations taken into a regional view of global models of care. Now, Escala following the acceptance from the Ministry of Health, the recommendation was to achieve the possible saving of 44,000 lives annually by the deployment of a learning management solution and the deployment of a series of e-learning across the Ministry of Health. The training was available for more than 5,000 MOH, clinical and administration staff. As a result of this piece of work, the Ministry of Health were awarded the Global Sepsis Awards for 2018 from the Global Sepsis Alliance. And this was for recognition for the work they've done on sepsis. This is a good example of how integrations of digital health can support organizations and ultimately save lives. I want to pass you over to Dr. Vijay Rai, who's going to talk a little bit more about this, but I'm going to come back to you later on in the session to talk about the benefits of health systems. Over to you, Vijay.
Hello, everyone. Thank you, Kavaldeep, for inviting me to speak at this Congress. Just to introduce myself, I'm Dr. Vijay Rai. I'm a practicing GP or family physician in some countries, and I'm a subject matter expert for Escala, and I've got multiple various roles as well. So I'm going to look at this in a different view to what Eric's looked at. Eric's looked at hospitals and organizations, and I'm going to look at healthcare systems, which is at a system level or a healthcare service level at a country level. So I'm going to start by what actually do we mean by fragmentation in healthcare systems? And there are multiple definitions that you will get around. However, this one actually is the one that delivers the key points that I'm going to raise today. So fragmentation in healthcare delivery means that the system misalignment of incentives or lack of coordination that spawns inefficient allocation of resources or harm to patients. So what do we mean by this? You'll see a few examples. I'm going to start off by going through a patient story, and that patient story will illustrate the issues that a fragmented healthcare system can have and what the possible solutions will be. And then Siva will give you a few examples of what we've come across in low and middle income countries. We'll start off with a patient story, and this is Mr. M, who's a 42-year-old South Asian male seen in the emergency department for a fever. The discharge letter was sent to the GP or family physician saying that this is likely a cold. In the letter, it had that he'd had numerous investigations while there, blood tests, chest x-rays, And there was a small note to say on urine dipstick, there was some glucose in the urine, and it said no action needed by the GP as this was a viral cold. Patient had been given the advice and any treatment that was necessary. 2 years later, he had some blood tests done as he was feeling generally unwell, and found that he was in kidney failure. Further tests showed that he also had diabetes, which was the likely cause of his kidney failure. Despite all attempts to control these conditions, within 1 year, he was on dialysis and awaiting kidney transplantation. So what are the issues that this case has raised for us? And the first one is that the emergency department assumed that it's not their role to act on the glucose in the urine, as the patient had presented with the viral cold. The GP or the family physician assumed that there was no action needed, as the discharge letter said no action was needed, and he thought that probably some of the blood tests could have been for diabetes, and obviously that had been ruled out. And how did this impact on the patient? Therefore, the care of this patient was fragmented, which actually led to a delayed diagnosis of diabetes and him having then kidney failure related to it, and then needing dialysis and being prepared for transplantation. This delayed diagnosis resulted in a few issues, and these are the issues that I wanted to highlight from this case. So there's a patient safety or patient harm issue. This patient actually came to harm because a full picture of his health wasn't taken when he was seen. It was rather fragmented health services that were looking after him. There was obviously reduced quality overall, because this should never happen. It's an incident that needed reviewing and looking at what lessons could be learned. And obviously there was an increased cost to the health system, or even to the individual, depending on which health system you are in, because now rather than medications or diet or even insulin, he is now requiring a dialysis and a transplantation. That's massive cost impact. And there's going to be medications that he'll have to take for the rest of his life, which are not that, which are quite expensive. And then there's the issue about it being inefficient. The inefficiency in the health service is because this patient, if there was a urine that showed that there was glucose in it, and there were bloods that were being taken for other reasons in the emergency department, they could have added the bloods to that, and they could have got a result to say, is this diabetes or not? And yes, they didn't need to act on it, but actually would have then necessitated maybe the general practitioner or the family physician to act on it. And therefore, the whole system was inefficient because the patient then needed to have another blood test 2 years down the line to be able to say that this is diabetes, and that's obviously caused his renal failure. And I'm sure you'll agree with me that overall, the outcome for this patient was very poor. So as a health system, what can we do, or what can health systems do to try and stop this fragmentation and to help with trying to integrate health systems? So Eric's already gone through how organizations do it with regards to digitalizations and that. But when it comes to healthcare systems, we need to step back a bit because there are two key things that need to be done before you come to the digitalization part of it. And the first one is commissioning. So for those who are not so versed with these phrases, commissioning is a process by which health and care services are planned, purchased, and monitored. This should ensure that any service commissioned is working within an integrated health system and not in a silo. So when you're planning a service, you need to make sure that there is integration that's put in it so that the right contract can be made for it and the right service can be made so that the service doesn't work in a silo and it works in an integrated health system. And then obviously the next thing that comes after you've commissioned a service is the contract. And the contract is a legally binding agreement, and it should ensure that there are enablers and incentives in it to make sure that the organization or the service starts to integrate and does not work in a silo. And in some cases, there should be penalties for that as well, if it depends how good the contract is. And then we come to the main thing, and I'm not going to speak much about it because Siva is going to give you an example of what we've come across in middle income and low income countries. But unless the services are not actually, or organizations are not actually given the tools to be able to do it, to integrate, even with the best commissioning and contracting efforts, this isn't going to be successful. And with tools, digitalization is one that we're focusing on here, but in reality, for integration, communication is key. Whether it's done via digitalization or via any other method, that's a key enabler, a key tool to be able to use to start integrating services. So I'm going to now pass on to Siva, who's going to go through a few examples about healthcare systems in low and middle income countries, and especially concentrating on the tools that they've started to use in this. So Siva, over to you.
Thank you, Vijay. Excellent, thank you, Vijay. So, patient experience in health systems in low and middle income countries continue to face considerable challenges in providing high quality care, affordable, universal, accessible and integrated healthcare. This was pretty much explained by Eric, which was brilliant. This has resulted in the integration of healthcare in e-health and m-health, use of mobile technology in low income countries. Developing countries are experiencing an unprecedented increase in the number of users in cell phones and internet technologies, as well as a decline in prices of devices and services. As a result, many health programs, implementers and policymakers are exploring the extent to which E and M health, referred to simple as e-health, can help address the challenges faced by resourcing constraints and health market terms in availability and the quality financing of integrated healthcare. Now, the example I wanted to give you was back in 2018, Escala had about 100 GP come over from Egypt on our GP patient pathway. And part of that training which we gave them was to visit GP practices and to engage in general practice. So we showcased a lot of digital solutions, but one in particular took their interest was a patient record system. Because the process in Egypt at the moment is, at that time in 2018, they were using a record-based system where they had a filing room where they'd file family packs of paper-based patient records. In 2018, Egypt implemented a patient record system as a result of the universal health insurance to support 108 million people. This program is going to last for 10 years in Egypt, and they are taking it by governor, section by section, implementing patient record systems. Now, the benefits, what were the benefits to the integration of digital health in this particular patient record system? Now, from a doctor's point of view, it was fantastic, because in Egypt, in some of the hospitals and the general practitioner offices, they were seeing up to 100 patients a day, giving them five minutes, even less of their time, because they needed to see every patient. Now they've got a minimum of 15 minutes they give per patient, because they've got a scheduling system, a pre-visiting scheduling system from the patient record system. They've also improved patient outcomes by having a system in place. They've also provided accurate data by having a digital system in place rather than using a paper-based system. They've improved data quality, and it can be accessed at any time. So they've reduced time by actually going to look at these paper-based systems and utilizing the data they have got. They've got securing patient information with others, which means this information can be sent safely and securely through a system, and they've standardized patient care. Now, the Ministry of Health are very happy with this system, and they could see more integrations of digital health through the universal health insurance system in Egypt. It's a fantastic example of integration of digital health. And I think that we need to see more of it in low and middle income countries. And Escala is trying to pioneer it with the things like the sepsis learning and the learning management solutions which we're presenting out there. So I want to end on this, but I also want to say thank you for giving us the opportunity, myself and Vijay, to talk to you about this. So over to you, Kaldi.
Thank you. Thank you, Shiva. Thank you, Dr. Rawal, and thank you, Eric. Eric, I think you would like to take a question that was raised by Mark Baron, who's the Vice President of the International Diabetes Federation. Very important question. Go ahead and take that.
Yeah, thank you very much. I think, this is very important because you know, one thing is to talk about and good intentions, but we say that, you know, good intentions doesn't make anything. So it's true that if we really want to be serious about, you know, making patients real stakeholders in the organization, it means that institutionally we need to have all in place. That means from the start, a systematic representation of patients in the board. For any technical committees, we need to have patients on board. Even in the hospitals need to put places to make the patient association, that the hospital is part of the home. That means any patient can go and seek advice and meet people from patient associations in regard to their dominant disease or their health concern. So all these are elements that really can allow the patient organization, the patient and the community to be a stakeholder. There are some countries where this is in place, and this has to be systematically put in place, and that's the responsibility of those in charge of the organization, and we really advocate for that in the IHF to push our members to go in that direction.
Thank you, Eric. Shiva and Dr. Rawal, either of you two, I've got on my WhatsApp, somebody's not coming through, he's scared to pose this question, but will you be taking your program of sepsis and others to Africa and maybe other low middle income countries, because they've seen this, your results, and I think they're really, really impressed with this.
So yes, we are. So sepsis deaths are 1 in 5 globally. We know that. It's above 14 million people a year off the planet die of sepsis. So we want to come to Africa, low middle income countries. We are actually talking to Egypt at the moment to do a study with them. You know, we've got all the global subject matter experts on our team to support that. So yes, absolutely. It's certainly one of my passions to save as many lives as we possibly can through learning, through marketing and awareness, public campaigns for people to be aware of sepsis. And it's shown in studies now that COVID has been related to sepsis, and the symptoms are very similar. So absolutely, yes, we would love to support low and middle income countries, and we are certainly coming in that direction.
I think the next question, as tomorrow is World Patient Safety Day, I keep reminding everybody, please wear something orange to mark that. Dr. Jinmal has said, asked role of decision-making involving patient and their healthcare in patient safety. How big is this, and how will defragmenting healthcare systems and decision-making help in that? We know tomorrow we also have got Dame Sally Davis and also the chair of Global Sepsis Alliance, Conrad, joining us. What do you think? Does defragmentation help us in patient safety in sepsis matters? Either
Yeah,
I can start with Eric and then pass on to the next two. Yeah.
You want me to start?
Yes, Eric, please.
Yeah. So definitely, I mean, that's a critical element, because in organizations you may have, a systematic incident reporting system that allows really to capture what's happening and to involve as much as possible the patients in identifying when it is really related to a process. Because when we talk about patient safety, we really have to make the difference between all what is related to processes to what is related to individual malpractice, for which that has been identified and eventually people trained, or if it's really a tough malpractice, they need to be judged according to the rules and regulations. But what really happens, and that's where integration is so important, is when you have this kind of pass over the game. That means, you try to put the incident not on your side, but on the side of the other who has been involved in the care process. And that's the worst situation, because in this case, you always fall in the gap in between the two, and nobody is responsible. So the integrated system should really make sure that there is a overall responsibility, and that it is impossible to just, push up the blame to the other whenever anything happens. Everybody has to take it seriously, and the problem has to be sorted out collectively.
Thank you, Eric. Vijay or Shiva?
Yeah, I can take that. But what I was going to say, actually, Dr. Louis on the questions page has actually answered it. So, patients are key in decision-making process. And even if you use digitalization in this process, the patient is going to need the information to be able to make a decision. So as long as the patient doesn't get the information, the patient will not be able to make the correct decision. And in Mr. M's case, unless he knew that someone had done a dipstick and that there was glucose in it, and what the implications that could have been, he wouldn't have known that he needed to act on it or someone needed to act on it. And yes, as Dr. Louis said, that you can bring in a digital system. However, it doesn't need to be digital, but digital systems are the best ways, as Dr. Louis kindly pointed out, that, it can flag the abnormal results. It can, AIs can be put into place as well for this. But a simple thing that the patient actually gets the letter that goes to the primary care physician as well. So they can read it and they can ask the questions from there as well. So it could be as simple as that.
Thank you very much. I'll have to wrap this session up, and I think it's such a fascinating, we could continue. But my next session for all the audience is the Carol Osai talk. I don't want to delay that because Carol Osai was one of our trustees. Unfortunately, she passed away due to COVID. And I think this patient safety issue and blood safety will continue after this session. So I would now thank the panel for your time and effort, and let's continue our relationship. And those of you who are now in the audience, could you please go back to the auditorium and then log on to the next session. I'll be waiting there with my excellent panel, and let's make Carol's memory a good memory. I think she really loved IAPO, and she was really passionate about her work. And God rest her soul, and I think let's continue her work together. Thank you very much, and see you next session.
Thank you, Goldie.
Thank you. Goodbye.
Bye-bye. Goodbye. Bye, everybody.
Bye.